All right, the clock just struck 2, so we'll go ahead and get started, at least where I am. I'm on Eastern Time. Thank you for joining us for our May webinar. For those of you who are joining us for the first time, I'd like to extend a warm welcome and remind all attendees that a recording of this webinar and all of the slides will be published on our website, fcctaskforce.org, as well as shared in a follow-up email, which we encourage you to distribute widely to your colleagues and your network. Each of our webinars is dedicated to the NICU children of one of our speakers, and today we have the honor of dedicating this webinar to the NICU children of 2 of our speakers. Today's talk is dedicated to Zachary, son of Yamile Jackson. Thank you for using your family's story to advance skin-to-skin care practices around the world, Yamile.
Thank you.
We're also dedicating this session to Lelis, Bauzá, Vernon's sons, Bobby and Charlie. Lelis, thank you for all that you do to ensure family voices are centered in NICU quality improvement work. Please take a moment to review our webinar etiquette. We ask that you mute your microphone when you aren't speaking, that you turn off your camera if you're multitasking, and that any questions and comments spoken or written in the chat be respectful, non-discriminatory, and non-judgmental. We appreciate your help in making this space as safe as possible. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser's NEC Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy that exists in healthcare and to empower everyone to contribute. I'd also like to acknowledge Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, MJN, for sponsoring this webinar, and congratulations on 120 years of leadership in pediatric nutrition. This work wouldn't be possible without our esteemed organizational partnerships. A warm welcome to Newborn Pediatric Hospital Medicine Hospitalists, New York State Perinatal Quality Collaborative, and Prevent Blindness. We appreciate relying on you all to share upcoming webinars, office hours sessions, and newsletters, and are grateful for the opportunity to spread the word about your events and achievements as well. It's incredible to see so many family-led organizations alongside healthcare-based associations, and these partnerships is what part of makes the FCC task force so special. We would like to share that May 15th is International Kangaroo Care Awareness Day, which was founded by Yamile Jackson. Her organization has created free awareness resources that I'll link in the chat. Please take a moment to check it out so your NICU can be prepared to educate and advocate this month. May is Necrotizing Enterocolitis Awareness Month, with May 17th being NEC Awareness Day. Founded by Jennifer Canvasser after the tragic loss of her son Micah, NEC Society is the leading nonprofit dedicated to research, education, and advocacy around NEC. I'll drop a link to the free toolkit that can help your unit recognize NEC awareness this month. As we move on to FCC Task Force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Malathi Balasundaram and Colby Day are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, and myself are former NICU parents. Thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing, non-birthing, and bereaved parents. I'd also like to thank our healthcare partners for their time and support. It's rare in our local units to witness such authentic collaboration between the various disciplines of practice you represent, and we appreciate that you embody our key strength of equal partnership between all healthcare professionals and family partners. We'd like to thank Executive Council members Lauren, Kelly, and Aaron for their insights and expertise during their time with us. Their dedication to FCC in the NICU is sincerely appreciated, and we wish them the best as they step down from their executive council role to focus on other priorities. We're grateful to each of these wonderful individuals as they continue to support the FCC task force as organizational partners and active members. We would like to welcome Katrina Moline, Executive Director of Hand to Hold, to our Executive Council of Family Partners, as well as welcome back Beth Simonton, co-founder and Executive Director of ICU Baby, who has found time in her busy schedule to rejoin our organization in an Executive Council capacity. Join us in welcoming Nishan and Erica to our Executive Council of Family Partners. Nishan is a NICU dad and serves on the Family Advisory Councils of the California Perinatal Quality Care Collaborative and of the Alta Bates NICU. Erica is a NICU mom and serves as the NICU Patient and Family Support Specialist at Children's Mercy, Kansas City, where she's making strides in their unit's FCC practices. We're grateful to have both of your insights and expertise as part of our organization's leadership. I'm excited to share that we've got over 2,250 members from 49 of 50 US states, 8 of 10 Canadian provinces, and from 68 countries around the world. Since our March webinar, we've welcomed members from Democratic Republic of Congo, North Macedonia, and Taiwan. On to committee updates. Work continues on the Presence Study Toolkit, which will support NICUs in implementing unlimited parental presence, even in the face of a respiratory pathogen like COVID-19. Jesse and Mia are creating a position paper to show our community where the Family-Centered Care Task Force stands on the importance of equity, diversity, inclusion, and belonging in the NICU. They plan to create guidelines around ensuring nonverbal messaging in the NICU is consistent with FCC values and bring an EDIB lens to our work to ensure it's reflective of our commitment to health equity. Daphna and Alex are busy sharing FCC task force related events, resources, advocacy opportunities, and education on our social media platforms. Please take a moment to follow us. Our domains are linked on the homepage and footer of our website, as well as at the bottom of email correspondence. The newsletter committee published its spring edition with summary of our March webinar and related resources, an FCC task force executive council update, and the quarterly ARIA's Journey Supporting Families Beyond Discharge and Trauma-Informed Care Corner articles. I'll drop a link in the chat where you can read and distribute, and it's worth repeating that units who share our newsletter with their colleagues and who print and post them in their staff spaces are reporting increased success in obtaining buy-in around family-centered care practices. Let us do that heavy lift for you. We would also like to share that our 2023 quality improvement work has been published in the Journal of Perinatology. It was important to us to make this article available to all readers and are happy to share that this publication is open access. I'll drop a link in the chat where you can read it. This month's poll is centered around protocol and guidelines for fingernail length, artificial nails, and nail polish for NICU staff and families. Each of our monthly poll questions comes to us from FCC task force members, and your responses help them and others to improve care. We appreciate your participation. Links for both of these QR codes will be dropped in the chat. We've presented 19 webinars so far, with this being our 20th. Please utilize our webinar database located on our website under both the webinars and resources tabs to view and share all past FCC Task Force webinars. We encourage you to distribute these widely among your colleagues and invite you to subscribe to our YouTube channel so you can be the first to know when we upload a new webinar recording. And with that, I'm going to pass it off to our fearless founder, Malathi Balasundaram, for an update on our NICU FCC Measures Survey.
Thank you, Morgan, for keeping me and keeping us all organized and being the backbone of this organization. Thank you. If you don't know me, I'm Malathi Balasundaram, a neonatologist and FCC Task Force founder and co-chair. Thank you, everyone, for joining our 20th webinar, and great to see so many familiar faces. You're probably tired of reading my emails about this NICU FCC Measure Survey. I'm going to repeat again and we truly appreciate 86 centers, it's 86 as of today, for taking the time to complete this comprehensive survey. 59 centers have agreed to an interview with our research team, with 30 scheduled already and 21 completed as of today. So due to popular demand, we have reopened the survey for centers that would still like to be participate. Deadline for completion is being July 31st. And Morgan will share the registration link in the chat. So if your center is not participated, please take a moment to participate in this survey. I'm pleased to introduce the first talk speakers and thank them for accepting my last minute invitation. And before that, I want to share a brief background story. As Morgan mentioned, our advocacy team is working on creating an implementation toolkit of the present study. One of the chapters focused on skin-to-skin care. I'm honored to collaborate with Yamile, and we wrote about how to support families when they feel drowsy or unintentionally fall asleep while doing skin-to-skin care. It created some buzz among authors who are passionate FCC advocate, so we thought it would be a great webinar topic to talk about. And I'm curious and want to learn what the current practice is. So we asked you all quick 2-question survey. And thank you for taking the time to complete it. As you can see in this slide, first one is how you respond when a parent shows signs of drowsiness or unintentionally falls asleep. And 64%, the top responder, they gently wake the parent and reposition the baby. And the next top answer was stop the session and provide education and support. I'm glad that I invited Yamile and Ashley to share their expertise, so we will learn from them. And also we asked the second question, how do you support your family? And more than half responded, they don't use any safety device and on verbal instructions on close staff supervision. That's how they support the families. I understand the financial aspect of having the safety device and all those things, but is that the right thing to do for families? So let's ask the experts. And next slide, Morgan. If you listen to the January webinar, you are familiar with this figure. We don't, if you can go back, Morgan, thank you. So how do we phrase this? We don't do that here. Instead, how can we phrase this? How could we do that here with the growth mindset? And is there an opportunity for us to improve? And with that, I want to introduce Yamile, a NICU mom, innovator, and founder of International Kangaroo Care Day. And Ashley is a researcher, nurse scientist from Cincinnati, who collaborated with Yamile and published multiple papers on this topic. So we will share the detailed bios in the chat and those publications in the follow-up email. And take it away, Yamile and Ashley.
Thank you. Well, thank you so much for inviting us. It is exciting that everybody's talking about it. Everybody is looking to see how that we can improve kangaroo care, and Ashley and I are super excited to do this presentation. So thank you so much for inviting us.
Hello, everyone. Really nice to meet you. My name is Ashley Weber. I'm an assistant professor at University of Cincinnati College of Nursing. I'm also currently practicing NICU nurse. I work with hospitals all across Ohio and the country, and I have, like, the last 4 or 5 shifts had nearly all of my parents sleeping in Kangaroo. So where I practice, it's actually the norm, and we have specific risk controls in place to make sure that parents can sleep and they can do so safely, and they can get the longest duration of kangaroo care that they can. I like to say to my parents, as long as your bladder and breasts can allow. Breast or chest can allow. So kangaroo care is the best part of my job, hands down. There's nothing more magical than helping a parent get into KC for the first time and bond with their baby and all the amazing benefits. So thanks for having me here.
Thank you, Ashley. I'm so excited to work with you on these topics. So I am Yamile Jackson. I am Zach's mom. Zachary was born at 28 weeks in 2001. So he was a very, very tiny baby. I didn't know the NICU existed. And before Zachary was born, I had finished already my PhD in ergonomics and safety engineering. And when I am Colombian, so I've heard about kangaroo care when it started. I was a girl watching the news. There were only 2 channels, so you can't miss the news when you're at that age. And it was a method that the kangaroo care, started in Colombia, and then 20 years later, I found myself in Houston, kangarooing my baby. There was a sign outside that said kangaroo care, ask your nurse. I was in a NICU that was very, very progressive, where I was, I was there to hold my baby. My husband did kangaroo care. I didn't know that dads did kangaroo care. So, he kangaroo care, probably the only first guy that kangaroo 24 years ago. But there were many things in the NICU that made me really want to help Zach. For example, how does he know that I love him? Because I love him and everybody knows that I love him and a lot of people love him. But how does he know? We need to feel loved to be able to fight, especially in those very difficult moments when survival is, imperative. And I wanted to give him love. And I found that kangaroo care did exactly that. I also heard that the touch would create an aversion. They will create an aversion to touch when they grow. And I felt that that was a very isolating world. So I wanted to make sure that he didn't create that aversion to touch, because it would be a very isolating life. About 3 weeks after Zachary was born, we had a flood in Houston that shut down the hospital, and it was inspiration of the movie called 14 Hours and a video from Oprah as well. And I kangarooed Zach. My husband got a crash course on how to bag him. And that's how we saved, everybody working in the NICU to save the lives of the 79 babies that were there. And in those very dark moments, I made a promise to Zach that his pain and struggle to survive were not in vain. So I'm an engineer, I'm a problem solver, and I was experiencing the problem. I think I was in a very unique position to look at these problems and create a solution. So for kangaroo care, I identified 3 different gaps on implementation. And I'm not in the is kangaroo care beneficial. I am in the how do we do it, right, safely. So there are thousands of papers already, published, and there are a lot of people talking about it, doing everything. But my engineering side is on implementation, on safe implementation. So there were 3 basic roadblocks for implementation. One was education and awareness. I started Kangaroo Care Day to try to solve that problem, and it has been amazing. I don't know how many, if you can say in the chat, how many of you celebrate Kangaroo Care Day. It would be awesome to see. I can't see the things now because I have the screen, but I would love to read it later. The second one was education and safety and infrastructure. A lot of the staff that we talked to said it's more work for me, and I wanted to understand why. And it was real because it kept coming up. Like a lot of people said, it's more work for me. So I wanted to, dig a little bit better of why is that? Because in my view, if the mom is taking care of the baby, why would it be more work for you? So our contribution is research, products, risk management, tools, all for implementation of family-centered care, neuroprotection, zero separation, kangaroo care. And the last one was metrics. We're not counting kangaroo care. And if we don't count, everything that we care about in the NICU is counted, to the last drop of milk, to, how long, and medicine, everything. But by not counting it, we feel that we're sending a message that is not important. So we're not doing it. Today's talk is basically on risk management and the research that we've done on risk management.
So, what is this talk and what is not this talk? This talk is not about criticizing your current practice or how you respond to risks. We're not suggesting that you need to change your hospital's policy or clinical protocols. We are not here to judge your implementation efforts or progress, but what this talk is about sharing the work that we've done to create a safe experience. Even if the parent falls asleep during Kangaroo or is encouraged to fall asleep during Kangaroo care with, again, risk mitigated. And we want to bring together the parent and the professionals' perspectives grounded in research and our lived experience. And then we want to empower you to decide next steps. Once safety is ensured, only then can really true connection thrive. So skin to skin is direct upright contact, although it can be diagonal, in some cases side lying and with head midline for the baby. But the baby's only wearing a diaper and on the parent or family member's bare chest. So you really want that skin to skin contact for the greatest amount of benefits. I'm not going to review the benefits here for this group. We have a wealth of resources and references on the next slide, but we know that Kangaroo care, reduces morbidities, mortality, promotes brain development, has so many positive effects for our patients and their families. And it's also has a lot of cost savings as well. That being said, you do need an infrastructure in place to support long durations of Kangaroo care. Next slide, please.
Okay, so this is what I found when we were looking at why isn't more work for you. And what we could conclude was when the babies are on the bed, the nurse has full control of the safety of this baby, and they have the responsibility. Once they put the baby on the chest of the parent, they give the control to the parent, but they keep the responsibility. And this is why the instructions for the parent are all these things that are here, because this is what you guys take care of when the baby is on the bed. But once the baby goes to the chest of the parent, you're giving that control of the safety to the parent. So they need to be mid-aligned. They cannot slide. You cannot sleep, because obviously, baby's not safe, lines uninterrupted, everything that you take care of when the babies are on the bed, that's what you're asking the parents to do once the baby goes to the chest of them. I would be interested to know what instructions do you give the parents that we didn't list here? And then you say, enjoy, it's the best time that you will have with your baby. And we enjoy it. Definitely. It's life-saving. Now, when you have, especially dads, and I want to know if you feel this way, if you've heard it, when you have the risk, for example, like fathers are very risk averse. They don't want anything to happen to the baby during Kangaroo care. Not that moms do, but we're more risk seekers. Like we want to hold, just tell me that I want to hold them. But fathers are more risk averse. So if we tell a father, you can hold your baby, but if, they say what can happen, and you say, well, it can extubate the baby. First thing they say is, let my wife do it. So for that, we are delaying the Kangaroo care for dads until they are comfortable or the babies are extubated in their care. So, we don't think it's fair that we are delaying Kangaroo care. There is also a push for bringing Kangaroo care closer to the birth. I kangarooed Zach on his second day of birth, so on the 16th of May. and I held him every day. I asked, my nurse asked me if I wanted to hold him, and I said no. But I said, why? I said, I don't want to hurt him. I felt that I had hurt him enough for not giving him a healthy start, and I didn't want to contribute more to his pain. And she said, it will hurt him more if you don't hold him. I always think if she would have said anything else than that, for example, okay, we can do it tomorrow or anything, I wouldn't be here talking to you about Kangaroo Care. It was definitely show me that I was very important for Zach. Ashley?
So we know that there have been a lot of standards out there recently that have been published, specifically the WHO, that states, we want our babies, including our NICU babies and our level 4 NICU babies, we want them to be in Kangaroo 8 to 24 hours a day from birth, so like 24 weeks and older. And so now it's really, the standard has been set, and it's how do we do this safely, right? And I personally don't know how you could get 8 to 24 hours of skin-to-skin care a day without sleeping. It would be incredibly difficult. And so when you skin to skin for longer periods, the risks really, really add up. And so it's really, really important to have a device, training, equipment, the things that you need to make sure that that baby is in place and supported, and we're not relying on the parents' hands for safety. So when a parent falls asleep, and in the case when I practice, when a parent is encouraged to fall asleep, what really is the issue? Well, the issue is that their hands no longer provide safety or support to the baby, right? That we don't have a support mechanism to make sure that the baby isn't sliding, tubes aren't being dislodged. And so really what we need to do is to address that mechanism, right? We need the equipment and the infrastructure to ensure that that baby is in the same position on the parent's chest, and we're not going to have lines and things being pulled out. And so we've talked about this in our previous papers, and you can see that here on the bottom of the slide. I will say also, next slide, that it's not just falling asleep when the parent's hands can be an issue, right? If they go to like reach for their cell phone or reach for a drink of water, or if they're distracted when talking to a family member. So it's not just falling asleep. Really, the issue is that when the parent's hands is what's responsible for holding the baby in place, then it really does become a safety issue. Because I mean, even me, I don't think I could hold I know I couldn't hold Emmett for like more than 45 minutes without my arms getting really, really tired. So next slide, please.
So there are very valid reasons why hospitals do not allow Kangaroo Care, to sleep in Kangaroo Care, I mean. It is not a biological reason. It is not an evidence-based care that says that something happens if the parent falls asleep. It's purely safety, because if the baby is dropped, which I have heard of already 5 hospitals that in the last 2 years, babies have fallen from Kangaroo Care to the floor, and we're helping them, prevent the second one. I encourage you to prevent the first one, because having an infant falling, it's horrible for everybody. It's terrible for the parent, because the parent feels that it's her fault, and because she was the one holding, or he was the one holding. The nurse, because she's near, is her shift. Remember, I said she keeps the responsibility. The hospital loses millions of dollars. There is mental health issues. There's reputation of the hospital, even though falls is not something that needs to be reported, but we will hear it. And injuries, for example, if the baby slides, if the baby extubates, there is this paper that we put in here that shows, and this is several years ago, so it's probably more than that now, that each unplanned extubation can cost the hospital $50,000, plus all the other things that happen too with the guilt and all that. So the concern is extremely real, but it is not, it needs to be solved. It is not something that we say, okay, well, it's going to cost money. It's more costing money not doing the right thing than when you do the right thing.
And, what I love about this paper is that it shows that if you put appropriate controls in place, you can decrease those serious safety events. So I encourage folks to look at this paper. And it's terrifying. If you look at the fiscal year 18 data, that is so many unplanned extubations, right? But with really, with the infrastructure, the equipment, the training, again, everything that they did, they were able to significantly reduce those unplanned extubations. So I would say it absolutely is possible. You just have to, again, put the infrastructure and support into long durations of kangaroo care. Give it the time, the attention, the money that it deserves. And as Yamile reminded me, if you look at fiscal year 20 of that graph, one unplanned extubation is too many, right? And so even there's room for improvement, and just having a zero tolerance, and just, again, always having like continuous quality improvement with Casey is so important. And we have references here that you can look at for your leisure.
Okay, so I want you to step into my shoes and come to the NICU and hold your baby. I fell asleep with Zach, and it was, like I say there, it was absolutely glorious. I loved waking up with him. I was physically and emotionally exhausted. I was sleep deprived. Moms in the NICU don't get really good sleep at home either. My oxytocin was flowing, which I didn't know it was oxytocin. I just knew that I was really relaxed with him. We calmed each other when we were in kangaroo care. The monitors were quiet because Zachary was stable on my chest. I had a really comfortable chair, a recliner, and they gave me a warm blanket, and they told me to relax. So I did. And without knowing, I fell asleep. Next thing I know, I'm waking up with this beautiful experience. And about half a second later, I knew that I had put my baby in danger. So, I did not know I was going to fall asleep. A nurse did not catch that I was going to fall asleep because it happened so quickly. And she didn't wake me up. So, she took very good care of me while I was sleeping, because I feel she felt that I needed that sleep as much as I did. But I put my baby in danger, and I remember I'm a risk manager, and I felt really, really bad, even though it was that feeling, I still have it with me. So to explain to you what a session of a kangaroo care, we found this analogy, which is a short airplane ride. A lot of people have taken short airplane rides, and imagine a very long ride. For example, from Houston to London, or from Houston, to Australia. When it's a short ride, you go to the bathroom before, you don't plan very much. You're going to go up and down. You don't have, beverage service. You can't watch a movie because you can't, watch the whole movie. So, and, if it's any discomfort, then, you can tolerate a short ride. However, when it's a long one, the airplane gives you things to be occupied. a pillow and the light for reading and movies and, text and headphones, and they give you water. And basically it's because they want you to be comfortable, and that this ride doesn't feel 3 times longer than it is, and that there is no disruptions to safety. Even when you're sitting, you put your seatbelt on, right? So, doing long trips, it's different than if you have short ones. So if you're NICU, you only do short sessions, your preparation is different than if you want them to do 3-4 hours or 6 or 8 hours or 20 hours a day. So it's like if you tell a parent, go ahead and rest and unwind, but if you fall asleep, the plane is going to go down. And but enjoy the flight. So either you relax or you stay really, really, concerned that what you do is going to bring the plane down. So let's talk about risk. And this is something that each one of you does every day. You evaluate and decide. Everything is on risk the entire time. We just want to give you a little bit of framework so you can use it with Kangaroo Care and with anything that you use, basically. So a risk is exposure to danger, harm, or loss. If it's something positive, then it's not called risk, it's called opportunity. You don't say, I have the opportunity, the risk of winning the lottery, right? You have the opportunity to win in the lottery. But if it's something bad, then we call it risk. And it has to be an event and a consequence. So for example, falling asleep. Falling asleep is an event. What happens if you fall asleep? Do you fall? Do you have a heart attack? What is it that is the consequence from you falling asleep? So the same event can have different consequences. So each one of those is going to be a different risk. When you talk about unexpected or unanticipated, those are the unknown unknowns. For example, when Zachary was in the NICU, we didn't know that the generators were going to fail. But in 2025, you should be ready for evacuation because it has happened many, many times. We don't know when it's going to happen, but your hospital is probably, and your NICU is probably prepared for loss of power, evacuations, because even though mine was the first one, there has been so many evacuations for different things. I can't hear you, Ashley.
Kangaroo Care, especially with our high-risk patient populations in the NICU, including intubated infants, it is a very high-risk procedure. But as we saw in that paper that I talked about earlier, it is possible to reduce the risk. So, and they acknowledge Kangaroo Care can be a very high-risk situation. So it's so important that folks have training, that it's included in annual competencies, that nurses and RTs that we precept our folks to be comfortable with these transfers, right? And that the infrastructure that you need is there, especially as we do Kangaroo Care with sicker and smaller patients.
Okay, so let's talk about the 5 steps that you do with the risk. What do you do? First of all, you establish the context. Let's say we want to celebrate Kangaroo Care Day, and we want to increase kangaroo, or anytime increase into Kangaroo Care for intubated babies. The risk identification, again, parent unintentionally falling asleep or intentionally, and then what is the consequence? Let's say that it's leading to an unplanned extubation. It can be many things, but we're dealing just with unplanned extubation. So because that's one risk. So we Then we do an analysis. What is the likelihood that this event will happen? And then what is the impact? In this case, the likelihood is quite big that the mom, let's say that we want long sessions. The mom can fall asleep and the impact is very severe because the baby can extubate, right? So that one is in the red section. What we want to do is find ways, because we know it can happen and we know it's a very high impact, to either close a little bit, move the probability of happening, or move the impact, or both. So those are the risks that we are going to tackle first, the ones that have high probability of impact and it have high probability of happening. For example, there are high impact that you know, very unlikely, like earthquake, right? The impact will be horrible, but we've never had one, or then you do something, but you might want to just keep that one without doing anything because you don't think it's going to happen. Now, there are 4 things that you can do for risk response, and you have done all of them in different things. And we're going to talk about a little bit more, but basically is you avoid the risk, you accept the consequences, you share the risk, or you control the risk. And again, in the next slide, we're going to talk about that. But once you decide what you're going to do with that risk, then you do and monitor and adapt, and then you start all over again. So let's talk about what the risks of the response for parents falling asleep during holding that the baby extubates. Okay.
So when I saw the poll results, I did have a little bit of a heart attack, but I know practices are so varied across the country. And I think what a lot of folks want to do when they say we don't allow parents, to sleep in kangaroo care, I think the goal there is to just eliminate the risk, right? Because what we said is there are so many very high risks if we don't have the infrastructure in place. So if you don't have a reclinable chair that's comfortable, if you don't have a hospital bed, if you don't have kangaroo care devices and your babies aren't on monitors, then it's completely understandable that you would avoid the risk, because again, it's so high. You don't have a mechanism to keep the baby safe and contained, right? The problem with that is, and as we see in the poll results, is folks have acknowledged parents are already falling asleep, right? Like I know that the intent is to, prevent parents from falling asleep, but if the vast majority of folks are already saying yes, and then we have to wake parents up, then the risk situation really has already happened. So then it almost becomes a sort of like accept response by proxy, because so many parents again are already sleeping, and again the outcomes could have already happened, right? Where really you're not really even avoiding the situation that you're planning to avoid, right? And so in my clinical practice, I mean, I couldn't really even fathom doing these long durations without a hospital grade bed or a recliner, and without a KC device. The last couple of parents I've had, they kangarooed for 2, 3, one mom 4 and 5 hours. And I don't know how you would do that if you don't have something in place to keep the baby secure. So
and also it has to do with who are you talking to. So for example, I talked to a respiratory therapist that was retired. And I was telling him that I found this article that said that it's $50,000 for the hospital to do for an unplanned extubation. And he's like, no, it's not. We just intubate again. So it really depends on who you are and how do you see the problem and how you're going to do this exercise. So that's why it's important that you do like, very, very diverse people, because everybody thinks differently. When you share it, the risk is, for example, when you tell the parent, okay, you are going to do this, you are the one doing this, or you buy more insurance if something happens, or if you have public announcements for that. I mean, there are so many things that you can do share. Or you can do control, which is know that the risk is happening and you control so that risk of happening goes down. You don't want the event to go down because you want parents to be able to fall asleep. You want is the risk to go down. So support, parent training, simulations with the parents. Check out your evaluations for your intubation. Can you do something so it doesn't extubate as easily? Always tell parents that we are watching you. If you do it at home, somebody has to be watching you as well. And then work so to put things in place to be able for you to let them fall asleep and the baby not to have, this is the protocol will. Now, sleep is not a failure. And this is something that I want to stress, and I want to know if you agree. It is not a failure of the parent. It is not a failure of the staff. It's the failure of being able to set an infrastructure to be able to manage kangaroo care. It is predictable. It shouldn't be punished. And the systems and not a willpower should be the one protecting the infant. Purpose of kangaroo care wrap device, keep the baby in place if the parent falls asleep. If the parent is not asleep, you can still, use it because you are going to use your hands and you're going to have the attention away, like Ashley was saying. Beware of those that say you have the kangaroo care device, but you shouldn't sleep in it, because it's like telling you, your car has a seat belt, but please don't get in an accident, because we don't take care of that. There is a test if the mom is laying down, and if you feel that she can get up without holding the baby and the baby doesn't slide, then the baby is going to most likely be safe and secure.
So I know we're running out of time here, and I really, really want a little bit of space for questions. So I will just state that we've already covered this, right? That we need the parent to be reclined, and we need something to support the baby. A device I would encourage people to try all those out there. Make sure that whatever device you choose, that it's secure, secures the baby is not sliding, because there have been instances, where devices are not approved for sleep, and then, things happen. So, I will say that, SSC, it's work, but it's part of my job, right? That's, we work as professionals, and it's the best part of my job. And there's, a lot of investment, to train the parents up front. But once you get them comfortable, I mean, the payoffs are just amazing, right? And it actually saves you time in the long run, because the parents have the babies, they're supported, monitors are quiet, and it's just amazing. Yes, like training them up front, does take a lot of dedication, but then, after a couple, like a week or two, then they can get really, really comfortable, and it's actually a time saver. So with that, I think we just open it up for questions, comments, and I would love to hear from folks, who are also doing something similar, and their experiences.
Thank you, Ashley and Yamile. Thank you for this great talk, and I think it's opened up. I was it's not a practice in my unit, I'm honest with you. So I think it is opened up so many of our eyes. So we just take this to the next level. And I wanted you to address the question in the chat with the safe sleep practice and transition home, and how do we educate parents? And is there any tips that you guys use in your unit?
Yeah, so we well, I will say as a nurse, I really pair the safe sleep with sleeping in kangaroo care. And in our paper, we do talk about this. And shout out to Jennifer Hopper, where they developed an amazing algorithm, because we knew that was going to be, you know, a concern. And so as the patient, you know, transitions to safe sleep, like from a medical physiologic standpoint, to then we sort of ramp down parent sleep in kangaroo care as well. There's different thoughts to that. The WHO guidelines do state that, you know, parents should be encouraged to sleep in kangaroo care, you know, or not sleep, I'm sorry, be in kangaroo care 8 to 24 hours a day, even at, you know, at home.
Yeah, you
But
can
I think
do,
with it,
you can do
it's
24 hours kangaroo care if you don't sleep.
but
It's
yeah, so
impossible.
it's
No,
and
but it's not just one person. It's not one person doing
Yeah.
24 hours. Is the baby has to be in kangaroo care for 8 to 24 hours. So it can be mom, dad, uncle, whoever. It doesn't have to be the mom, because obviously it takes a village. But with the use of the kangaroo care device, you give the control back to the nurse, which is the important thing. The nurse still controls the safety of these baby.
and most parents understand, you know, you're in a NICU, there are monitors on your baby. We have, you know, professionals who are watching your baby at home. You know, you don't have that or might not have that. So, you know, please, you know, either have another adult watching you, or if you don't have those same safety mechanisms in place, then according to the risk management framework, avoid is an absolutely appropriate response. But there's a lot of folks doing work around the world, you know, who have a different take on that, I will say, after going home. So.
In the presentation, in the last slide, we included questions about kangaroo care devices that you should ask the manufacturer. And that answers several of the questions that I see on the chat. So many of these things, you have to ask the manufacturer about it. How do you hold the baby? You know, can the mom sleep during kangaroo care while they're using your device? How do I access the baby? Is it single family, or it can be rewashed? How many times can it be washed? How do you access the baby? How do you do breastfeeding during kangaroo care? All these things, all those are there.
Okay. Thank you, Yamile. And so we are running out of time. So if you wanted to ask your question in the chat, or you wanted to just you're the next speaker. So
it's just a very quick thing for those of you that have cardiac units. A cardiac chair is the same thing as a kangaroo chair. Borrow from your cardiac units, and you can save
I think,
some money.
I think geriatric units use the same chairs as well. But the most important thing is you sit on that chair and you pretend you're the mom and see how can you make this pairing, because the problem with buying chairs in the NICU is that the person buying it is not the person using it. So they're not ergonomic or comfortable. They just need a chair. So they just buy a chair.
Okay. So I wanted to hand it over to Colby Day. So who's going to introduce the next talk speakers. Thank you, everyone.
Thanks for inviting us.
Hi, everybody. I'm Colby, and I'm very excited to introduce Sue Bowles and Lelis Vernon, who I've known for several years and miss very much from my location now in New York. Sue is an expert clinician, educator, and leader in perinatal nursing. She's a doctorally prepared clinical nurse specialist and certified in neonatal nursing. Sue has spent more than 40 years caring for babies and their families in some of the leading maternal and children's hospitals in the U.S., and she currently works as a nurse consultant for Florida Perinatal Quality Collaborative. She has a strong passion for evidence-based neonatal nursing, family-centered care, and leadership development. Lelis is a NICU mom and nationally recognized healthcare consultant, author, and international speaker with almost 2 decades of experience improving maternal and infant health outcomes.
She combines lived experience with clinical expertise to advance quality improvement, patient engagement, and health equity. She serves on national advisory boards, including the AAP, Stanford, and Vaughan, and is a Harvard-trained leader in safety, quality, and informatics, known for co-designing impactful, family-centered care models. Please join me in welcoming Sue and Lelis.
Thank you. It's nice to be here. Can we have the next slide? So I dabble. I'm retired from the bedside, but I dabble. So I do have a few disclosures. I've worked with Angel Eye, I've worked with Water Wipes, I work with Nurse Builders and Abbott Labs. So my disclosures. Lelis, how about you?
I don't have any disclosure.
Next slide. And one of the things as we get going, what our objectives is, we want to review the evidence. We won't spend a lot of time. Provide an assessment criteria that clearly define infant, parental, and institutional readiness for skin-to-skin care. I will tell you, if you do a literature search, don't do skin-to-skin care because you'll get things like oil of Olay. You really have to put Kangaroo care in. We just discovered that. We want to examine evidence-based strategies to implement SSC within the NICU. And we wanted to exemplify that family engagement and collaboration in a statewide project, because in order for the quality to take hold and really be sustained, the families must be involved. Lelis, do you want to add anything to that? Okay, next slide. So how did we select family-centered care? Well, we actually have an infant care health committee in the state of Florida. We look at data, we look at other PQCs, we look at what guidelines are out there and what our stakeholders are talking about. And then we poll our Florida NICUs. There's about 75 NICUs in the state of Florida. I believe in this project, we had almost 40. So we got a lot. And then the Infant Health Committee decides, and that's how we came up with this. Next slide. I was fortunate to be the nurse consultant on this, and I worked with Mark Hudak and Sam Sukala, but there's a very important person whose picture is missing on this slide, and that is Colby Day. And when we get to the next slide, I'll tell you why. And Lelis is our parent consultant. We actually have a parent consultant who is a consultant on all FPQC projects. Next slide. So we came up, well, we didn't come up with, Colby Day came up with PAIRED. So PAIRED stands for Participation in Care and Decision Making, Individual Recognition of Each Infant and Family, Respectful Collaboration with the Families, and Education for Families about Care After Discharge. So I really wanted to give Colby credit because she actually started something in 2020 when she came up with this, because now we name all of our projects. We could try to come up with a mnemonic or something so that we name all our projects. Next slide. So how did we have someone first? So Lelis, you want to address the parent and the representative and the caregiver survey?
Sure. So I've been doing this for a while, and I have to say this is perhaps the proudest engagement I've had, because this really reflected an investment in the value of the opinion of families at the bedside. And so, yes, the pair had many firsts. We created not only a parent, not only do they have me as a parent representative, but we created an advisory committee, an ad hoc committee to inform this project. We developed a caregiver survey that we're going to share later on. And because the inception of this project started with 2020, and if you remember, we started in January, and so surprise for all of us, in March, we were shut down. So we started the project as a pilot initiative, and then we expanded it later on, a year later, to what resulted to be PAIR Plus. And so the way that families informed this project was, first, we collected the interest of all families on what would be the main focus related to skin care and facilitating family-centered care in the units throughout the state of Florida. And then we collected. And so next slide. So what we did was give families a list of, well, first we started an open dialogue, and I'm very proud to say that we had non-speaking families as well.
I don't think so.
And I was able to speak with those families in Spanish, translate their interests, and categorize the main areas of interest. So then we started prioritizing what the potential better practices for this project would be. And then we compare them with the advisory council that was mostly clinicians. And so we were very happy to see that our collective interests were really matching. And that's how we informed the key driver diagram that we designed for this project. Next. Sue?
So basically, we had several potentially better practices that we identified. Skin-to-skin care was the number one. Inclusion of families in daily rounds. Identifying infants and families by name and correctly identifying them. And complex care conferences and early medical education. So those were all very important to us. Next slide. So we decided to focus on skin-to-skin care. And why? Well, it utilizes all 4 domains of family-centered care. The evidence base showed optimal outcomes for babies and their families. It was easily instituted with minimal costs, and it was easily measured. And, you know, we were talking about, you know, chairs and everything a little while ago. I remember something, Bob White actually has a thing on the, we actually used it, but it comes from 2013. And he said, if he was designing a NICU today, he'd start with a kangaroo chair in the center and design the NICU around it. Design the room around it. So it's something to really be aware of. Next slide. So this is, and I know it's a busy slide, and if anybody wants any of these, all of our projects are available on our FPQC website, FPQC, you just Google it and you can get it. So this is what we aim to do by June of 23. Each NICU will achieve a 20% increase in baseline from the percentage of infants who receive skin-to-skin care from at least one family caregiver within 3 days of clinical eligibility. And that was important because at that time that we started this, that was when they were saying babies should be midline for 72 hours to minimize the risk of IVHs. Now we know that some of the evidence has changed since then, but that was what we were doing. And then supplementally, we wanted to have the perception of culture, and because we were changing a culture is what we were doing when we started this. We knew we were changing the culture, and then we had our primary drivers, our secondary drivers, and our potentially better practices. Next slide.
So one more thing, Sue, before we go, I remember that we had a lot of discussion with Kobe here, and personally, can you go back one slide? Personally, here, all the family advocates in this call would really appreciate that. I don't know you, but I've been doing these key driver diagrams for a while. I have never seen one that had the primary drivers with the 4 pillars of family-centered care: participation, dignity and respect, collaboration, and information sharing. And that to me really gave the framework within which we were going to roll out this project. But it was really framing it and anchoring it in the main concepts of what we meant by family-centered care. Then the second drivers are the ones that are shaping up the project to be more skin-to-skin. And finally, the PVPs that absolutely involved the family. But this to me is one of my personal trophies, designing a key driver diagram with the 4 pillars of family-centered care. Next,
Exactly.
and Sue.
Okay, so what we looked at is, I want to give you some data, and there's a slide in here, it's coming up, and you're all going to be really excited about it. Lelis and I love this slide, but we started at about 50%, and by the time we finished, we had gotten to about 60%. So we felt that we had met our aim, which was really important to us, with the prompt initiation of skin-to-skin care. Next slide. And some of these slides are a little busy, but we were able to look at it by race and ethnicity and birth weight. And what you can see is, looking at this, our Hispanic and Latino families were the ones that really had the biggest growth. In terms of it, we were really excited about it. And then we looked at our birth weight categories, and it was interesting because we did really well, and it was well talked about during our coaching calls that we had with our teams, that we did really, really well with our small babies in skin-to-skin care, our tiny babies. It was when those babies got out of the isolate, got a little bit bigger, that skin-to-skin care fell off. And they fell off when we were talking to the parents. It was because they wanted to normalize them. They wanted to dress them. They wanted to get more toward that point, which is why it fell off a little bit as the stay in the NICU progressed. So it was kind of interesting for us. Okay, next slide. We looked at mother's own milk. Obviously, you know, skin-to-skin care really promoted that. We were really happy about that. We thought that was wonderful. In every category it went up. So we were, and it was kind of nice because the project that we had done in like 17 and 18 was the Mother's Own Milk project. So to see that was this skin-to-skin project was helping us sustain our gains that we had made in the Mother's Own Milk project was really exciting for us. Next slide. Okay, so SSC education and training. Now, this is what was really interesting. We did a lot of training, and we actually developed competencies. And I know Mary Coughlin's on the call, and I want to thank her because she was kind enough to allow us, from her evidence-based practice book, to use. She has a competencies for caregivers at the bedside, like nurses and docs, but she also has one for families. And we were able to adapt those competencies and get them out there to our hospitals so that they could use them. So it actually really helped us with that education and training, because we were able to do simulation and have that guideline, as well as have a competency, because we all love competencies in the NICU, you know that. All right, next one. And yes, we are working on going to publish this. So what was our data? Well, we had to have 10 infants per month. Now, I will say not every one of our NICUs could do 10 infants. 10 was the goal. We had some that just weren't big enough to get 10 infants per month. So we would take what they had. So what we looked at was skin-to-skin care and adverse events during skin-to-skin care. We looked at mother's own milk and primary caregiver, and that was our patient level data. Our hospital data was staff education. Did they have a policy, and did they have standardized documentation? And then 48 hours prior to discharge, we had a family caregiver survey. And Lelis, I don't know if you want to address that.
No, that's fine.
Okay, next slide.
I'm managing the chat.
Okay. All right, this is my slide, guys. This is our slide, okay? If you look at these numbers, 2021, 4,169 SSC episodes, 22, 11, over 11,000, and in 23, over 5,000. And if you look at our unplanned extubations, yeah, we had 3 we had 3, 4, and 2, and in 2022, the one that was 2 unplanned extubations was the same baby, because this little guy who was in this unit had a really curious little tongue, and he could tongue that tube out without any problems. But if you look, what is the one thing that nurses always say, or caregivers always, you know, healthcare providers say? Oh, we can't do skin to skin. The baby's ventilated. They're going to extubate. Well, guess what? They didn't. They didn't. And the big event, the ABDs, we actually are doing some more digging in this, because we think it was if the caregiver, if the healthcare provider went over and turned off the monitor, they counted it as an ABD, and we don't know if it was really truly an ABD event. That was our biggest events. Hypothermia, as the project progressed, we got better at it, and it was really getting people to understand how they should be doing the skin to skin and really keeping the baby skin to skin, because you know, we just didn't have the events that everybody thought we were going to have. So I find this slide just, you know, it's out there. You know, the biggest people we had to convince to do it were our respiratory therapists. And I will tell you also, with the policies that we did, all of the units went to a policy where at least 2 people had to be responsible for the transfer to the parent. So, and we also taught sitting and standing. And I really want to thank NANT, the groups from NANT, and I see Christy's on, because a lot of their work helped inform what we were doing as well. So we really had a good evidence base, and we were really excited when we saw these results, because, you know, that was the first thing. But the very first kid that was ventilated in this project was at one of our smaller hospitals, so level 3. But they did an oscillator. They took a 23-weeker on an oscillator and did skin to skin with that baby on the oscillator, and was extremely successful. What they did is they trained an entire team, and then they had other people come in and watch, and they have been very, very successful since then. So when people say, you know, the baby's on an oscillator, it can't go skin to skin, yes, it can. I'm here to tell you, yes, it can. If this very small hospital in the middle of Central Florida can get a baby skin to skin safely, it can be done. Okay, next slide.
No, so two last points here, and I want to share some of the things that I learned from my engagement with the Vermont Oxford Network. And it is that at some point, many years ago, we did a study on the alarm settings, and there was a huge variation in the alarm settings from one NICU to another. So with that, if we were digging a little more on the setups of, you know, significant A's and D's, we would find that there is a lot of room for improvement on the setup, and for combing through those numbers that I think would be even lower. And the other thing is that we are opening also a new QI cycle, and the first thing that teams report is that, oh, the parents don't want to Kangaroo. And once again, I would like to share that from the family perspective, we don't know what we don't know. And so if we are not taught and trained about how to properly skin to skin, and I think that the previous speakers said it all, it was fabulous. And really, we need your help for being better parents while we are in the NICU. So this, I think, demystifies all those fears from the staff. We did a gap analysis also in this project, and it was how much training and proficiency did the staff have with standing and sitting transfer versus at the inception of the project versus the last, at the final part of the project. And it was huge. There was a lot of education that staff needed to have in order to welcome families at the bedside doing skin to skin. Next.
Yeah. Okay. And this was just some of the other statistics that we looked at in terms of the family-centered care aspects, dignity and respect, communication. We were really proud that we really, while we use skin to skin, we were able to really implement family-centered care within all of our units. And it's kind of an aside, but it's continuing it, because when we finished paired, we moved right into a project called Homeward Bound, which is based off the discharge guidelines out of NPA. So we went from paired skin to now we're preparing the families to go home. So we're able, and we're still doing this. The other thing, and thank you for setting up Kangaroo Care Day, because our units are still doing Kangaroo-a-thons. I'm still mad at Dr. Hudak. He still owes me a picture of him in a kangaroo suit. He still owes me that, and I'm not going to let him forget it. But we also do it for International Prematurity Awareness Day. And what we found in this project is that by having these days 6 months apart, really worked in keeping the sustainability, because people would gear up for the Kangaroo-a-thon, for Kangaroo Care Day, but they would also gear up then for the International Prematurity Awareness Day, because we would do Kangaroo-a-thons for that. So that really helped with the project. Next slide.
Yeah, there is one more metric that we did not put here, that we were running out of space, but it was a very important one because we had a spike in our data in May, and
Yep.
guess what? It was Kangaroo-a-thon, right? But then it kind of goes down, it flattens throughout the year. And so my big challenge to everybody that is working on skin to skin and improving your practices is to, how about we take our top performing data and we translate it into sustained improvement? And I think that, I think now I know this is a big challenge for everybody. Sustainability is always a challenge. But then with our teams, we said, well, this spike had very healthy hours of family engagement, right? Why don't we translate that into a process that can be standardized, number one? And two, why don't we push skin to ski Kangaroo-a-thon competition, a healthy one, for Prematurity Day? And that's what we did. So we had now 2 little spikes in data for May and November. So, but with that, I think it's important to recognize if a unit is able to achieve X amount of hours, I think that should be the goal for the standard of care provision.
And so it's really, it just is, so just to go back to our key driver diagram so that you can see that we met our aims, okay? So we encouraged family participation in skin-to-skin care. We provided early and continuing lactation support to promote breastfeeding. So we went, we got our 20%. We did create a culturally sensible environment supportive of skin-to-skin care. We changed the environment. And that's how we found out like different little things. Talking about a safety device. Some of our hospitals that didn't have a lot of money, you know the what they put over the Tocos belt, the I can't remember what you call it, but it's like a stockinette that you can put it over the Tocos belts. Well, it comes in different sizes. Some of our units that couldn't afford to buy a device actually had that, went to labor and delivery, and because they had different sizes, that became what they used. Another unit had moms go to the dollar store and buy a tube top. Different people became very creative in making sure we had those safety devices. And then one of our wonderful units got really creative and worked with her billing department and found out that you can use a device, you can buy a device as a DME, and you can bill for it and get that cost reimbursed. And I don't have the code on any of the slides, but there is, if people aren't interested, I can probably get you the code and you can use it as DME. And because it is a safety device, so because it's a safety device, you can bill it with DME. And I think we might have sent the code at one point to y'all here at FCC. So
yes, we have it.
Yeah, so there is a code and you can bill for it. So next one. So Lelis.
So yeah, so when you say, oh, we had a parent advisory committee, there are a lot of interpretations on how the families really interject in the creation of a project. But this was really a true co-design. And our families, these are 15 of the 20 families. So what I did was gather the voices of 10 families that had graduated the NICU more than 10 years ago. And then we had 10 families that were freshly graduated from the NICU. And my intention with that was giving you and everybody a longitudinal appreciation of the challenges that families have. And I was hoping, of course, that some of the challenges would have gone away, but this is what I meant by mentioning that we really combed through the voices of the consumer, in this S.Q.I.L project, the voices of families, their concerns, their wants, their needs. And it was really a rich appreciation that we were able to give the clinicians as we went on with this project. And again, we had half of the families were non-English speakers. We had translation of those conversations and then translation into data points extracted from those conversations. We were exploiting Zoom during the weekends because it was during the pandemic. So Mark Hudak and myself were actively interviewing families during the weekend. But nonetheless, this was just one part of the family engagement. Next slide. And I'm not sure if in the call we have Elizabeth Simonton from ICU Baby, but our engagement and partnership with ICU Baby was key. They are the largest volunteer group serving NICUs around South Florida, and they are expanding in the state. And they were really the ones that gave us the fresh voices from the NICU. ICU Baby is made up of not just families, but graduate NICU ambassadors, and my kids are in the picture, and they're proud ambassadors working with ICU Baby families in the NICU and by proxy with the FPQC. So some of the ways that we did put the voices out was create these cards on the upper left-hand side with a QR code. QR codes were the cleanest way to approach families, the most effective one, because we discovered that no matter what socioeconomical background families had, and especially immigrants having here in the NICU, they had access to cell phones and everybody could be quickly informed about this project. This information was furnished to families in English and in Spanish, of course. In the lower left-hand side, you have one of the two qualitative analysis that we did with interviews with the families. And we put a timeline there. It was really an exhaustive analysis. It was very informative. In the center, you have one of the 5 pages of the family survey, and we designed it around the 4 pillars of family-centered care. This was modeled with Mark Hudak and myself, and it was very family-centered because it was family-informed. And in the lower right-hand side, you have part of the spreadsheet with what we called Friends of the PQC, which was the large group of families that were contacted via email, via text, via calls to keep their participation throughout the project. This was not just a co-design by embedding their voices at the beginning in the key driver diagram, but it was really an active engagement throughout the project. Thank you.
So that's kind of our story, which is it's really exciting because even now as we go through coaching calls, we're still hearing that the units are really maintaining the skin to skin, and it's been really helpful. So I would just encourage you all. Again, the competency, the guideline, we actually got permission from Royal Children's Hospital in Melbourne, Australia, which is kind of funny because I live in Melbourne, Florida. So that's kind of our sister city. And they have a fabulous guideline that was evidence-based. And they actually allowed us to take that guideline and use that guideline. So the hospitals could just go into we have a toolkit and a toolbox where we have all our resources. So the hospitals can go in there and get that and then download it and adapt it for them as they need to. So it wasn't that they had to reinvent the wheel. Those of you who've been doing this, our motto, I was with CPQCC until I moved to Florida in 2013. I was down south, so I worked at some of the hospitals down there. But I am a firm believer in share seamlessly and steal shamelessly. you don't have to reinvent the wheel. So thank you.
Thank you, Sue and Lelis. That was wonderful. It's always so wonderful to hear all the work that guys are doing. I don't know if you were able to monitor the chat while you were talking, but you just got accolade after accolade for all of the improvements you've made and for closing that equity gap in particular. I know we're short on time.
But you know what, Colby, I'm going to interrupt you because you get some of the credit too, because you started this project. I know you had to leave midway, but just so that you know, Colby stayed with us on the project when she went up to Albany. Was it Buffalo? Someplace cold. I know that.
Rochester.
Someplace cold. And she stayed with us throughout the project. So I really want to give her credit too, because she was our physician, one of our physician consultants at the beginning, but then she also stayed with us throughout the project.
And with that, we had a funny map for Florida PQC. We had all of Florida and Rochester, New York.
Yeah. It's like those nice cups you have where, you know, someone moves and there's a little heart that connects the two states. It was great. And I credit paired with really getting our skin to skin care in Rochester off the ground. And one of the statements I wanted to make and see if you had anything else to add is you guys were able to accomplish a true giant multi-center quality improvement project with this. And I don't think we can overstate how incredible that is and how difficult it is to get centers that have differing cultures, that have different barriers, all to work together. And at least from the part that I was with, it seemed like your office hours were a huge part of being able to keep everyone together. I don't know if you have any comments on just your tips and tricks for these big multi-center projects, how to keep people together.
Well, we have coaching calls. So we have monthly coaching calls. So we divide, we have coach mentors. So we have a physician coach mentor and a nurse coach mentor. They're paired together. And so the hospitals go into these groups. And when they're in these groups, they ask the questions that we coach them, but the hospitals educate each other. Like somebody will say, well, I'm using Epic and we don't have this. And somebody says, oh, we designed Epic. Let me send you the steps, you know, of how we did it. So that was the biggest thing for us, is that those coaching calls, those monthly coaching calls. And I see they're asking how it's funded. We are funded. We are one of the few PQCs. We are funded. Now you're all going to be shocked, by DHS through the state of Florida. And our consultants are all paid. Okay, we're not paid a lot, but we are paid. It is not a volunteer position. So we not only, and it's free, all of our hospitals, because DHS provides it, our hospitals have to be involved with 2 projects with FPQC. It's a state law, and they don't have to pay for it. So
yeah. And I think that the coaching calls were really the place for cross-pollination. It's where the challenges of some of the units came up and the solutions from others would be shared. And it was a really rich collaborative.
Yeah, and I really think too that the hospital, the small hospital that did the oscillator, that just, I mean, that just went like wildfire, because obviously that hospital's we had 3 coaching calls a month because we had to split because you can't have huge groups. But everybody heard about it. And so that's how, and it just grew and grew and grew. And we started with 17 hospitals as our trial. And then we went from our trial into our full. So then we did another 18 months. So just about a little over 3 years. So
that's amazing.
Thank you.
Yeah, I was going to turn it over to Morgan to close us out. I know we had.
I know. I wish we could extend this another 30 minutes because this has just been such a wonderful webinar. And
well, if anybody's going to NPA, I'll be there next week for a couple.
Wonderful. Well, thank you all so much for joining us. We hope that you'll join us again on July 10th for our webinar with Jessie Barnes and Mary Coughlin. And as mentioned in the chat and at the beginning of the webinar, all the resources and slides and recording will be made available in a follow-up email shortly. Have a great day.
Thanall.
Bye, everyone.
Thank you.